sparing, preserving organs has become pretty commonplace in contemporary oncology. On this slide, you'll see a number of types of cancers in which we regularly practice organ preservation: anal, breast, esophageal, laryngeal, sarcomas, etc. There has, in fact, and Beacon plays nicely into this, patient power and patient advocacy has played a fundamental role in this adoption of organ preservation amongst, within oncology. In particular, there are many high-profile women activists beginning in the 1980s or so. Some names are listed here, who were really the main drivers of organ preservation in breast cancer. Here's some quotes. For example, "You mean I had a mastectomy for nothing?" And happily for women, surgical custom is changing. And these quotes come from a book by Dr. Mukherjee, The Emperor of All Maladies, which was a recent New York Times bestseller, and perhaps some of you have seen or even read that book. But that's just an example of patient advocacy sort of changing the paradigm within one cancer. In bladder cancer, the gold standard has always been cystectomy and remains so today. So the surgical removal of the bladder and reconstruction. Alternatives have arisen along the lines of bladder conservation. They all share similar goals of curing achieving cure, preventing failure, and providing a functional urinary reservoir and a high quality of life. So what is the modern alternative to cystectomy? It's called Trimodality therapy, bladder-sparing Trimodality therapy. It involves a maximal transurethral resection of the bladder tumor and contemporary conformal radiation therapy, and often radiosensitizing chemotherapy. This is the general paradigm here. I'm not sure if you can see my my mouse arrow here or not, but I'll move from the top down to the bottom. So it starts with a transurethral resection of the tumor, followed by an induction course of chemoradiation, and then a break. And that break is often approximately 3 weeks. Towards the end of that break, you visit the urologist again and undergo a cystoscopy to assess the response to that induction course of chemoradiation. And biopsies are taken of the original tumor site. If indeed those biopsies are negative and urine cytology is negative, meaning that there is no evidence of persistent or recurrent cancer, the patient then continues with consolidation chemoradiation to a full dose and the consideration of chemotherapy to follow all of that. If, however, at the time of that cystoscopic response evaluation, a non-complete response is found, meaning that there is still persistent or recurrent cancer, then a prompt salvage radical cystectomy is recommended. Those who get through consolidation chemoradiation will always be followed closely with surveillance cystoscopies every 3 months or so, at least in the first few years, to ensure that there is not a recurrence later in follow-up. For those who sustain a recurrence of their muscle-invasive bladder cancer in follow-up following all of this chemoradiation, again, a discussion of a salvage cystectomy is made. So that's the general paradigm. This approach has really been pioneered here in the U.S. at the Massachusetts General Hospital and under the umbrella also of a large cooperative group, the Radiation Therapy Oncology Group, RTOG. And over the years, there's been this paradigm of how to treat, when to use chemo, how to do the radiation has undergone an evolution to how we do it today. I won't go through the details. I'm happy to answer questions about that evolution. But basically, over the years, over these last 2 or 3 decades, we've gotten better at how we do both the radiation and chemotherapy. We've published our experience here at the Massachusetts General Hospital quite recently on a large cohort of patients, about 350. Here we've treated well over 400 patients in this way. But at the time of this reporting, we reported on 350 with muscle-invasive bladder cancer who were treated on these bladder-sparing protocols here at Mass General. There was long follow-up of these patients, and we looked at how they did in regards to survival. And I'll go through this reasonably quickly just to give you a flavor, but 3/4 of our patients were male, or are male, and that's quite typical in bladder cancer. More than half had T2 muscle-invasive bladder cancer, but a number had more advanced disease as well, meaning going through the bladder wall, potentially invading other organs. 2/3 of the patients had a maximally visibly complete transurethral resection of their bladder tumor prior to entering the protocol. And over 70%, and I would say today about 80%, achieve a complete response to that initial course of induction chemoradiation. If you recall, I'll go back to this paradigm over here. So at this point, at time of this cystoscopic response evaluation, currently about 80% are achieving a complete response and going on to consolidation chemoradiation. Still about 30%, it says 29 here on this slide, required a cystectomy at some point because either they didn't achieve a complete response or they developed a recurrent disease in the bladder in follow-up and still needed a cystectomy. But the flip of that is that 70% of patients retained their own bladder, which we find very encouraging. This is just a slide showing survival from bladder cancer over the years. This is very typical to what you see in surgical cystectomy series. One of the concerns is that after chemoradiation that there may be a wave of a lot of recurrences after 5 years, longer, the further you go in follow-up, but we really haven't seen that. It's really a flat line, as you can see, meaning that recurrences, if you're recurrence-free in the first 5 years after treatment, you're very unlikely to have a recurrence later, and that's very similar to surgery as well. Here I'm just showing a contemporary reporting of surgical series that I think you can tell that the graph looks very similar, meaning very few recurrences once you get past the first few years of follow-up. This curve just shows if you compare T2 disease, meaning muscle invasion in red, versus more advanced disease, T3 or T4, meaning going through into the fat layer beyond the muscle wall, or in fact even invading other organs like the prostate in men or the vagina in women, that of course those who have lower stage disease do better than those who have higher stage disease. However, even in the more advanced cancers, the T3, T4, what you're seeing is 50% cure rates at long term, 10, 15 years after treatment, which again, we find very encouraging even in those more advanced cancers. I'll skip over this slide. It basically says that those who get a complete response to that induction course of chemoradiation, that's the red line, do better than those who don't. We know that. And this slide just shows us, it's a busy slide, so I won't spend much time other than to say those patients who are able to have a visibly complete maximal transurethral resection of their bladder tumor prior to initiating on the course of chemoradiation do better than those who did not have a complete resection. They do better in terms of the complete response rate. They do better as far as avoiding subsequent cystectomy, potentially, and they do better in terms of survival as well. So this is why we encourage our urologic surgeons that we work with here to achieve a maximally ideally visibly complete resection of the tumor before embarking on radiation and chemotherapy. And here's a quote in one of the papers from one of our urologists, Niall Heaney, saying that the TURBT must be done with the determination to resect all visible tumor. Nothing less will suffice, and we agree with that. So who are the best patients for this bladder-preserving therapy? I think I've shown you that there are good results that are very comparable to cystectomy. But who are the best patients? Well, those who will do best with this treatment either have a solitary, meaning one T2 type tumor, or early T3 type tumors that are less than 6 centimeters. Those who do not have associated hydronephrosis, that's when there's blockage of the ureters that drain from the kidney into the bladder, and that blockage can back up to the kidney. Those patients are probably better served by cystectomy and not chemoradiation. We've already gone over that those who have achieved a visibly complete maximal transurethral resection of their tumor prior to starting this course of treatment do better. Those who have extensive carcinoma in situ, you may or may not have heard of that, but it's sort of it's like a precancerous finding that can sometimes be associated with the main bladder tumor. Though radiation is not really a treatment for that, so if there happens to be a lot of carcinoma in situ, we think cystectomy is probably better. The kidney function has to be good enough to allow for chemotherapies such as cisplatin-based chemotherapy. And really, we can comment mostly on patients who have the, so to speak, garden variety type of bladder cancer, transitional cell carcinoma, or urothelial cell carcinoma. That's where we have most of our results. So if there is sort of these alternative histologies like squamous cell carcinoma or some other kinds of histologies, we don't have as big a track record in chemoradiation for these rarer types of histologies. And also, to be honest, another point on this slide would be to say that those who have a bladder that is worth sparing, meaning some patients have really poor bladder function, that sparing the bladder is perhaps not worth it to the patient. And in fact, the cystectomy can serve them well by removing a bladder that isn't working very well. So we usually pursue bladder sparing therapy in patients who have a bladder worth sparing, so to speak. Moving on, this slide just shows that this treatment paradigm works equally well. Bladder sparing therapy works equally well in younger and older patients when stratified around the age of 75. And that's an important point because we have recently shown by looking at a large national, the National Cancer Database from the American Cancer Society, this is work from my group, that the majority of patients who are diagnosed with bladder cancer, in fact, the median age is in the 70s, and the majority are in their 60s, 70s, or even 80s or higher. So to say that we have equally good results in the elderly versus younger patients is saying a lot, especially when you see that the usage of cystectomy in the U.S. really drops off as patients get into their 70s and 80s. And in fact, if we look at the use of any aggressive therapy for muscle-invasive bladder cancer in the U.S. from this large national cancer database that captures 75% of cancer diagnoses in the U.S., what you see is that aggressive therapy defined as cystectomy or bladder-sparing chemoradiation is not really being utilized in especially the elderly patients. So you can see that only 40% of patients between the ages of 80 to 90 get what we call definitive aggressive therapy with cure in mind, and 60% are not. And what we would argue is that chemoradiation, bladder-sparing chemoradiation, could fill in this gap, meaning that patients who may not be as fit for cystectomy could still do very well with chemoradiation. I'll go over some of these slides rather quickly. Here are some of the chemotherapy agents that we use along with radiation. They're what you call radiosensitizing. They give you a bigger bang for your buck with radiation. They make the radiation work better. And in fact, these doses of chemotherapy are very, very low. They're sort of very low-dose chemotherapy, just enough to make the radiation work better. In fact, a study published in the New England Journal of Medicine this past year, in 2012, compared radiation versus chemoradiation, head-to-head. And I'll just show you in this next curve. Basically, this publication in the New England Journal showed that chemoradiation did better as far as preventing recurrences, this is the red line, than those who did not receive chemotherapy along with their radiation. So we know that trying to incorporate chemotherapy along with radiation, if a patient can is fit enough for both, probably produces better results. Currently, we have this national protocol that's open at many centers throughout the U.S. Through our cooperative group, the RTOG, for patients with muscle-invasive bladder cancer who remain candidates for cystectomy if needed, who undergo a maximal transurethral resection, and then are randomized to one of these two chemoradiation regimens. And that's the one we have open here at Mass General, and again is open, I think, at over 60 centers throughout the U.S. We also have this protocol open, and this is for the stage T1 patients. So these are patients who do not have muscle-invasive bladder cancer. They're earlier stage, but have a high-grade T1 type of tumor and have failed standard therapy, which is BCG-related therapy, intravesicular therapy such as BCG. So these are for recurrent T1 refractory to BCG patients, where often cystectomy is the next step, but what we're saying is perhaps we don't need cystectomy there, and we can do chemotherapy and radiation, chemoradiation, and still keep the bladder while curing the cancer. So we are looking at doing this in these T1 patients. We're looking at a number of biomarkers to see if we can predict outcomes better or even select patients for a certain type of treatment, meaning that they may do better with one treatment rather than another. What I can tell you is that quite a few bladder cancers actually express this HER2 protein. You may know of HER2 from breast cancer, and you may have heard of the drug Herceptin being used in breast cancer. Well, it is also expressed in bladder cancer, and so we have a trial that's ongoing in patients who express that protein, HER2, utilizing the drug Herceptin as well. Here is, this is, perhaps a little harder to figure out, but I'll just give you the take-home message. We've also looked at predictive markers to suggest, well, how would you do with one treatment versus another? And there's this marker, this protein called MRE11. And what we have shown is that if you are a high expressor of this protein, you do better with radiation than if you are a low expressor. And in fact, amongst the high expressors, those patients seem to do better in terms of survival of their bladder cancer, potentially, with radiation over cystectomy. So this has not been shown to proven in clinical trials. This is sort of ongoing research that is retrospective and trying to sort this out. However, it's exciting, and in fact, this Danish group here confirmed those results, showing again that if you look at the bottom right panel here, the radiotherapy cohort, that if you have high MRE11, you did better if you were treated with radiation than if you had low levels of it. And the flip was in cystectomy. Now we're looking at the top left-hand panel. If you had a high expression of this other protein called TIP60, you did better than if you had a low expression of it. And so what they did is they put these two protein markers together. What they suggested was that if you had low MRE11 but high TIP60, you would do better. You would be served better by cystectomy than radiation. And vice versa. If you were high MRE11 and low TIP60, you would do better with radiation than cystectomy. So I think what you can see here is an exciting area of research trying to use biomarkers to predict which treatment patients may do better with. Let's get to quality of life, which is a very important consideration with any of these treatments. I have here some images of a bladder, the bladder wall, with what are called telangiectasias that can cause bleeding after radiation. And on the bottom right-hand slice is a CAT scan picture of a very contracted, thickened bladder that I'm outlining here. These are things that could happen after radiation, but the question is, how often do they happen? And the truth is, those kinds of things are very rare. In fact, our group here did a quality of life study in patients, in over 200 patients, treated on our protocols with chemoradiation. And it showed that almost 80% had compliant bladders with normal capacity and good function. 85% of these patients had no urgency, urinary urgency, or only occasional urgency. About a quarter of the patients did have occasional to moderate bowel issues. Radiation can sometimes cause bowel changes, more frequent bowel movements, looser stools, that sort of thing. Encouragingly, amongst the male patients, 50% retained adequate erectile function. Following surgery, erections can be really compromised in male patients, and it appeared that there may be better function after chemoradiation, potentially. We also looked within our RTOG bladder-sparing studies and again showed very low rates of significant grade 3 or higher toxicity with chemoradiation, meaning that patients seem to do quite well with this. There have been a couple of comparative studies between chemoradiation versus cystectomy with incontinent or continent diversions. And the take-home message is there could be potentially a quality of life advantage to chemoradiation as far as psychological adjustment, physical well-being, energy, sexual function that we just discussed, and urinary function in the sense that you get to keep one's bladder, and therefore urinary function, quality of life was improved. Here is a questionnaire that was given by a group in Germany, actually, that commonly does chemoradiation. And the question asked to patients was, if you were to spend the rest of your life with your urinary condition the way it is now, how would you feel about that? And what I think you can see is that probably about 85% or higher of the patients answered that they were mostly satisfied, pleased, or even delighted with their urinary condition following chemoradiation, which is encouraging. So this has led one of my colleagues here to say the best bladder you will ever have is the one you are born with, even if it's had an aggressive resection and some radiation. We do believe that the acceptance of chemoradiation used in modern bladder-sparing therapy should not be limited by concerns of high rates of late pelvic toxicity, meaning side effects to the bladder or the bowels. In fact, I'll show, we just have a few slides left. This is a study, this is done by Michelle Donat, who's a very good urologist at Memorial Sloan Kettering Cancer Center. And what she did is she reported on radical cystectomies, over 1,000 of them. And she used a validated scale called the Clavian scale and reported on complications from a cystectomy within 90 days of a cystectomy, a very honest reporting. And what she showed was that about 2/3 of patients had more than one complication. 13% of those were very significant. When we grade them 3 or higher, they are significant complications. About 1/4 of the patients needed to be readmitted to the hospital because of those complications, and that there was a 90-day mortality rate, perioperative mortality rate, of about 1 to 2%. We compared, and I'll just sort of, oops, let me just go back here. What we did is we compared those 30% of patients who go through chemoradiation who ultimately still need a cystectomy because of a recurrence. And we compared the complication rates of those patients who had a salvage cystectomy after chemoradiation to those from Memorial Sloan Kettering who had a primary cystectomy up front initially. And if you just look at the red box here, those are grade 3 or higher toxicities. In the left-hand column here, it's from MGH for those who had chemoradiation prior to salvage cystectomy versus Memorial Sloan Kettering who had just a cystectomy, never had chemoradiation. And what I think you can see from these numbers is, yes, a little bit higher complication rates if you had chemoradiation versus if you didn't, but overall these are rather comparable numbers overall. So we feel that we can, so to speak, get away with doing a good cystectomy even in patients who had failed chemoradiation. European guidelines have recently been published saying that in selected patients with muscle-invasive bladder cancer, bladder-preserving therapy with cystectomy reserved for tumor recurrence represents a safe and effective alternative to immediate radical cystectomy. We were very encouraged by these guidelines. So in closing, combined modality bladder-sparing therapy achieves a complete response and preserves the bladder in around 70% of patients, while offering long-term survival rates comparable to contemporary radical cystectomy series. Quality of life studies that I showed you have demonstrated that the retained native bladder functions well and that long-term toxicity of chemoradiation to pelvic organs is relatively low. The incidence of a cystectomy performed for palliation of treatment-related toxicity from chemoradiation has been very low, and the morbidity of a salvage cystectomy after chemoradiation appears reasonably comparable to having a cystectomy initially, as we just went over with the Sloan Kettering data. So we believe that these results support the acceptance of modern bladder-sparing trimodality therapy for selected patients as a proven alternative to upfront cystectomy. The optimal regimen of chemoradiation, as well as the addition of rational molecular targeted therapy and personalized treatment selection based on biomarkers that we discussed, continues to be investigated. And this is the last slide, just to say that the contribution of bladder-sparing therapy to the quality of life of patients represents a unique opportunity for patients, urologic surgeons, radiation oncologists, and medical oncologists to work hand in hand in a truly multidisciplinary effort. So with that, I believe that was my last slide. I would be happy to answer any questions.
All right, thank you so much, Dr. Efstathiou. Everyone, please type your questions into that Q&A box on the bottom right, and we'll get started. For the first question, it says, can a person who has had radiation therapy for prostate cancer have radiation again for bladder cancer?
Yeah, that is a tough situation. Patients who have had radiation for prostate cancer, given that the prostate neighbors the bladder, and given that the doses of radiation used for prostate cancer are quite high, that would be very challenging to then come back and deliver definitive curative doses of radiation to the bladder. So we have seen the rare patient in this situation, and in general, we would recommend a radical cystectomy in this situation.
All right, thank you for that response. For the next question, the person wrote that they were recently diagnosed with stage 1 and carcinoma in situ and is being treated with BCG. The person wants to know if they would be a candidate for bladder-sparing therapy.
For carcinoma in situ, being treated with BCG, the answer would be no, because hopefully all you will ever need is that BCG therapy, and obviously close surveillance cystoscopies and follow-up. But the hope would be that you would avoid ever needing more invasive treatment such as either a cystectomy or chemoradiation. The hope would be that resections and BCG would be all that you would need.
All right, and just continuing along that line, can you explain more about why someone with carcinoma in situ, why the radiation therapy isn't very effective for that?
The reason is that carcinoma in situ is sort of this precancerous kind of change, and radiation really is not a treatment for that. It's not an effective treatment for carcinoma in situ.
Okay. And also you spoke about factors that would make someone a good candidate for the bladder-sparing therapy. Does the location of someone's tumor in the bladder play a role in that as well?
The location in the bladder does not play a huge role. I mean, there are some technical issues that we address when designing the radiation, but dependent on the location of the primary tumor. But the answer basically is no. We can treat it with any location in the bladder. So to address, so some patients have very small tumors at the dome of the bladder, and sometimes even a partial cystectomy is discussed with those patients as an option. That's one example of where location can drive management options. But basically, no, if the tumor is in the bladder neck, on the right lateral side wall of the bladder, on the left, we can use chemoradiation pretty much for any location. I see another question here that says, why isn't a patient with hydronephrosis eligible for bladder-sparing treatment? The answer is, it's not that they're not eligible. It's just really that they're, the results of patients that have hydronephrosis aren't quite as good with chemoradiation, and I'll tell you why. A patient who has hydronephrosis often has a tumor that has blocked off one of the ureters, where the ureter enters the bladder, called the trigone or the ureteral orifice. And that often means that it's either a bigger tumor or a tumor that could not be entirely resected at time of TURBT. Because getting a complete resection when it's around the ureteral orifice is much more challenging. And therefore, up front, you're starting with a tumor that probably isn't in the ideal category for chemoradiation for achieving the best possible outcome. That being said, and I have treated patients who have had hydronephrosis who, for example, aren't good surgical candidates. They aren't good candidates for cystectomy because of either their age or other health conditions, or they just outright refuse a cystectomy. Well, in that scenario, absolutely, we can still do chemoradiation. It's just up front, our ultimate results may not be quite as good as if there wasn't hydronephrosis, but that still doesn't mean that they're necessarily bad. We can achieve bladder preservation and long cure rates, overall cure rates, in those patients as well. There's no doubt.
All right. For the next question, what is the quality of life while someone is undergoing chemoradiation treatment?
Well, the average patient going through chemoradiation would experience during treatment some level of bladder irritation, causing them to urinate perhaps more frequently or urgently. We don't really see incontinence. That would be very unlikely. They would probably experience some change to their bowel habits. A little looser or more frequent stools could happen. But all of the above can be managed. It's usually not that bad, and there are medicines that can help if needed. The possibility for nausea is there with the chemotherapy and the radiation, possibly, but I really don't see that to be a significant issue. Some fatigue can build up over those weeks of radiation and chemotherapy. There can be some mild effects on blood counts, usually not a big deal. And all of these things tend to settle down once treatment is done. So many of my patients come in and are able to drive themselves in and basically live a normal life. I've had patients continue to work full-time through this treatment. So in general, I think patients can get through this quite well.
Okay, and just to follow up on that, you had mentioned the toxicity and that scale of 1 to 5. Can you explain a little bit more what that means?
Sorry, the grading 1 to 5, or the Clavian scale, or which scale was that?
The pelvic toxicity.
Yeah, so there's a way that physicians and those in the medical community grade toxicity, meaning grade the side effects that patients experience due to treatment. Grade 1 and 2 is expected in almost all treatments, and they're usually mild toxicities. So the majority of folks have mild toxicity with chemoradiation, like some level of mild bladder irritation or some mild changes to bowel habits, that kind of stuff. It usually is temporary and self-resolving, etc. Grade 3 means an intervention might be needed. Grade 4 means a hospitalization and perhaps even a procedure to correct something in a more significant way. A grade 5 toxicity is what we would never want to see, which is in fact death due to treatment. And so when we were talking about cystectomy and mortality rates, perioperative mortality rates of 1 to 2%, those are probably quite true because it's a big surgery. There's the chances of heart issues and other issues, clotting issues and things like that. So that's where that 1 to 2% comes from. But that's in fact a grade 5 toxicity, meaning that a patient passed away from that treatment. So that's how we grade toxicity from 1 to 5. Basically 1 and 2 is mild or moderate stuff. Grade 3 is a little more significant. Grade 4 means you have to be hospitalized, even sometimes go under surgery or something like that to correct the problem. And grade 5, of course, is what we would never want to see.
Okay. All right. Thank you. For the next question, over what period of time is the chemoradiation therapy given?
So basically, the way it works is that patients undergo a maximal transurethral resection of their bladder tumor. Often patients who come here to the Mass General will undergo another look by one of our urologists, a cystoscopy, and another repeat resection just to make sure we've achieved a maximal resection. Then there's a good 3 to 4 weeks just to recover from that procedure, and then you would start the chemoradiation. The chemoradiation would go on for roughly 3 to 4 weeks. The radiation is given daily, Monday through Friday. Chemotherapy would be on just certain days of the week. And then there's a break for about 3 weeks. A repeat look in the bladder to make sure that everything is good, that there's no recurrence of disease, and that's what I was meaning by a complete response, meaning that all of that is negative. And then continuing on with another 2 to 3 weeks of chemoradiation to finish the consolidation course. So in total, if you add up the 3 to 4 weeks and the 2 to 3 weeks, you're looking on the order of about 6 weeks in total treatment, but it's broken up with a 3-week break. Following all of that, there's a much longer break, and in some patients, we then consider higher dose chemotherapy on its own without radiation that is given potentially at that time. So it is a long investment of time to get through all of this, but it basically comes with a couple of more intense periods and then longer breaks and a lot of follow-up. But it is a program to which a patient has to be committed, needs support, of course, and needs a well-coordinated team of doctors to make sure that it goes as well as possible.
Okay. For the next question, person wants to know, would you lose your hair during the chemotherapy portion of the treatment?
Typically, patients do not lose hair during the chemoradiation portion of treatment. if there's any hair changes, it's usually quite mild, and many patients don't. It's all related to the choice of the chemotherapy agent. Some chemotherapy agents have a little more of that than others. However, as I mentioned earlier, the doses of chemotherapy are so low when they're used with radiation that usually that's not going to be an effect. Radiation itself would not cause any hair loss as far as hair on one's head. However, for those patients who go through the adjuvant chemo, meaning the higher full dose chemotherapy after one is done with all the chemoradiation, there could be some hair loss, again, depending on what chemotherapy agents are chosen by the medical oncologist.
Okay, and just for one more question, you spoke about the predictive markers, that MRE11 and the TIP60 that were related to somebody's survival rates. Can you speak a little bit more about how someone would be tested for those having the expression of those genes or those predictive markers?
How a patient would be tested for the expression of those markers?
Yeah, exactly.
Well, I have to say that right now this is very much kind of it's not really available for patient care. It's because it's very much sort of research that's being done to make sure that we understand this and confirm this finding. In fact, we're doing that research currently on some of the samples we've had at MGH, and it's really not available for regular clinical care at this time yet. Still remains very much investigational. However, we do hope that these kinds of predictive markers will, over the hopefully near term, enter more into regular clinical practice, where patients and the tumors that the patient has can be better characterized, such that one could even suggest that some patients may be better served with one treatment over the other. That's definitely where I think medicine is going, and in this case where bladder cancer therapy is hopefully heading as well.
Okay, well that's all the time we have for questions tonight. Thank you so much, Dr. Efstathiou. As you can see on the slide, we have one more webinar coming up next week on chemotherapy and bladder cancer. Also want to just let you know we're doing the walks for bladder cancer again on May 4th. You can still sign up or email us at walk@beacon.org. And once again, thank you so much for presenting, and to everyone for tuning in. The recording and slides will be available on the Beacon website within the next 2 weeks. Have a great night.
Thank you very much. Good evening.